Hello students, this is the presentation on hypertension and all the major diseases, MI, heart failure, stroke, renal disease. They in all those, hypertension has a big role in these. And it has been observed that there is a direct relationship between hypertension and cardiovascular disease. 1 in 3 adults in the US has high BP, and additional 38% are at high risk of developing hypertension. Now, healthy people 2020, for them, hypertension is a big concern, and they have uh, like high priority health indicators to which they pay a lot more attention than the other diseases in that category. And among those 26 high priority leading diseases, hypertension is right at the top. So it is their big concern. And they say hypertension is an important medical and public health problem. Now, in simple terms, hypertension is abnormally high pressure in arteries. Its etiology, the cause, is a result of peripheral vasoconstriction. And vasoconstriction, it decreases the blood flow to the end organs which are being supplied by the arteries. So we have arteries, and then we have arterioles, and these arterioles, they lead to capillaries, and these capillaries, they provide perfusion to the body tissues. And when there is high pressure in arteries, then there will be high pressure in arterioles, and then in uh, due to which eventually there'll be vasoconstriction in the whole passage of this blood flow path. And this vasoconstriction will lead to decreased blood flow. And when there will be a decreased blood flow to the tissues or the end organs which these arteries were supplying, then there is high blood pressure. It affects 33% of adults in US, and additional 30% they have pre-hypertension. What is the blood pressure formula? So it is blood pressure is equals to cardiac output times systemic vascular resistance. Blood pressure, the definition is the force exerted by the blood against the walls of the blood vessel, and it is primarily a function of cardiac output and systemic vascular resistance. Cardiac output, which we have discussed earlier, is the total blood flow through the systemic or pulmonary circulation per minute. It is now cardiac output also has a formula. It is described as the stroke volume multiplied by the heart rate for 1 minute. So, and what is stroke volume? Stroke volume is amount of blood pumped out of the left ventricle per beat, approximately 70 ml. And this is multiplied by the heart rate for 1 minute. So cardiac output is the total blood flow through the systemic or pulmonary circulation per minute. It is cardiac output is result of the stroke volume multiplied by the heart rate for 1 minute, and the stroke volume approximately is 70 ml, which is the stroke volume is the amount of blood pumped out of the left ventricle per plate. It's approximately 70 ml, and it is multiplied by the heart rate for 1 minute. So suppose if it is 70 ml of stroke volume, it is multiplied by heart rate. Suppose the heart rate is 70, then 70 times 70 will be 4900, and approximately um, half a, approximately 4900 of the 4900 ml of the blood will be uh, taken out for the systemic circulation. So cardiac output is a total blood flow and through the pulmonary or systemic uh, circulation per minute. So in 1 minute, if stroke volume is amount of blood pumped out of the left ventricle per beat, and if we take it at approximately 70 ml, then and we multiply it by the heart rate for 1 minute. So suppose the heart rate is also 70 and the stroke volume is also 70, then 70 times 70, it will be 4900 4900 ml approximately will be the cardiac output. Now, systemic vascular resistance is the force opposing the movement of blood within the blood vessels. The radius of the small arteries and arterioles is the principal factor which is determining the vascular resistance. A small change in the radius of the arterioles creates a major change in the systemic vascular resistance. If systemic vascular resistance increased and cardiac output remains constant or increases, arterial blood pressure will increase. Blood pressure must be adequate to maintain tissue, tissue perfusion during activity and rest. The maintenance of normal BP and tissue perfusion requires the collaboration or integration of both systemic factors and local peripheral vascular effects. So blood pressure is equals to cardiac output times systemic vascular resistance. Systemic vascular resistance is a kind of resistance or the opposite force which is um, within the blood vessels, which is within the arteries or arterioles. And how uh, much is the radius of these tubes, arteries, and arterioles? This is the principal factor which will determine the vascular resistance. If there is a small change in the radius of the arterioles, it creates a major change in the force which is opposing the movement of blood within the blood vessels. And if SVR or systemic vascular resistance is increased and carbon dioxide carbon cardiac output remains constant or it increases, then arterial blood pressure will increase. So blood pressure must be maintained adequately for tissue perfusion. Causes of hypertension: primary hypertension, or is also known as idiopathic hypertension, is elevated BP without any cause and concern, and it accounts for 90 to 95% of all cases of hypertension. Uh, exact cause is not known, but several contributing factors can be there. Some factors which can be there, which people think there might be, is genetic predisposition. So there might be some kind of genes. Gender also plays a role. Men are at greater risk of BP than women. Black males, African American males or black males are at higher risk for the illness. Also the diet, which is high in sodium, glucose, and heavy alcohol consumption, are linked to hypertension. Diabetes and obesity also plays a major role. More recently, a recent research which has been done, it indicates diets low in potassium, magnesium, and calcium are also associated with hypertension. The other causes of hypertension are secondary hypertension, pheochromocytoma, hyperthyroidism, hyperaldosteronism, Cushing syndrome, renal disease, and arteriosclerosis. Um, Arteriosclerosis, we just covered this. It's fatty plaques in your arteries, and these plaques makes your arteries very narrow. And when there is such a narrow space, the blood has to struggle very um, a lot to pass through these arteries, and so the blood pressure goes very high. The pressure of blood within the arteries goes very high. Secondary hypertension is which is that means the hypertension is related to the underlying diseases, and that underlying diseases can be pheochromocytoma, hypothyroidism, hyperaldosteronism, Cushing's, or renal. Now, pheochromocytoma is those are just benign tumors in the adrenal medulla which secrete epinephrine and norepinephrine, and that leads to hypertension. So pheochromocytoma, they are benign tumors in your in the adrenal medulla which secretes epinephrine and norepinephrine, which leads to hypertension. Hyperthyroidism, it is high thyroid hormones which leads to increase in heart rate and cardiac output, which thereby increases the blood pressure. Hyperaldosteronism, it is too much of this hormone which is aldosterone in body, and it leads to increased sodium and water. So, and as there is more volume, more pressure. So that's why there is high pressure. Cushing syndrome, it's too many of all the steroids, including aldosterone, which leads to increased sodium and water in body. Renal disease, it leads to high blood pressure, or high blood pressure leads to renal disease. Now, this is a little bit of confusion. But yes, renal disease and hypertension have a connection, and the high pressure eventually damages the glomeruli, and there is less blood flow through the kidneys, and the kidneys try to fix the problem by activating their renin angiotensin aldosterone system, and angiotensin, which plays a very great role in this renin angiotensin aldosterone system, which is also known as RAS, is a peptide hormone that causes vasoconstriction and its subsequent increase in blood pressure. So this makes the patient more hypertensive, and it can cause more damage to the glomeruli of kidneys. Left untreated, the left untreated the blood pressure, this can progress to renal failure. All the on causes of hypertension, the thing which we can change is also lifestyle. So obesity, sedentary lifestyle, smoking, stress, alcoholic consumption, and increased salt intake, they all contribute to hypertension. Hypertension is persistent elevation of systolic blood pressure greater than and equal to 140 millimeters mercury, or diastolic pressure greater than and equal to 90 millimeters mercury, or current use of hypertensive drugs. Let's go to next slide. Prehypertension is systolic BP 120 to 139 millimeter mercury, or diastolic, which is 80 to 89. And I want you to remember the hypertension and prehypertension numbers. The blood pressure can be classified into several stages. There is one called isolated systolic hypertension, and it is an average systolic blood pressure greater than and equal to 140 millimeter mercury, with diastolic blood pressure less than 90 millimeters of mercury. Systolic blood pressure increases with age, and diastolic blood pressure rises until approximately age 55, and then it starts declining. Control of isolated systolic hypertension decreases the incidence of stroke, heart failure, and death. Hypertension is also subclassified as stage 1 and 2 and it's dependent on severity of elevation. The classification of BP is based on the average of 2 or more properly measured BP readings on 2 or more office visits. So isolated systolic hypertension has this criteria, hypertension stage 1 has this criteria, and hypertension stage 2 has this criteria. The nurse determines that the patient has stage 2 hypertension when the patient's average blood pressure is what? It's 172 over 92, 160 over 110, and 182 over 106. So except for A, all B, C, D, they're all false, all wrong. So stage 2 hypertension is diagnosed when systolic blood pressure is greater than or equal to 160 millimeters of mercury, or diastolic blood pressure is greater than or equal to 100 millimeters of mercury. CS is a 40-year-old male who attends a community health screening. He stated that he has not seen a healthcare provider in a really long time. He's a truck driver who eats mainly fast food while on the road. He smokes a pack of cigarettes a day just for something to do during the long hours of driving and to keep me calm. CS is 5 feet 9 inch tall and weighs 230 pounds. His BP is 182 over 104. His heart rate is 90 and his respiration 24 and temperature 97. What risk factors for hypertension does CS has? So based on history and the information we have, it's obesity, tobacco, gender, excess salt intake, sedentary lifestyle. Risk factors for primary hypertension. The risk factors for primary hypertension are age, alcohol, tobacco use, diabetes mellitus, elevated serum lipids, excess dietary sodium, and gender. Systolic blood pressure rises progressively with increasing age. After age 50, systolic blood pressure is greater than or equal to 140 millimeter mercury. If after age 50 systolic blood pressure is greater than 140 millimeters of mercury, then it is a very important cardiovascular risk factor and it should be paid attention to. Excessive alcohol use is also associated with hypertension. Patients with hypertension should limit their daily intake to 1 ounce of alcohol. Tobacco use. Smoking tobacco greatly increases the risk of cardiovascular disease. People with hypertension who smoke tobacco are at greater risk for cardiovascular disease. Diabetes mellitus. Hypertension is more common in diabetes. When hypertension and diabetes coexist, complications, that is target organ disease, are more severe. Then we have high lipid level, and high levels of cholesterol and triglycerides are primary risk factors in atherosclerosis. Hyperlipidemia is more common in people with hypertension. Excess dietary sodium, high sodium intake can contribute to hypertension in some patients. We should decrease the effectiveness of certain antihypertensive drugs. Gender. Hypertension is more prevalent in men in young adulthood and early middle age, that is less than 55 years of age, and after age 64, hypertension is more prevalent in women. Family history. obesity, ethnicity, sedentary lifestyle, socioeconomic status and stress are also another risk factors for primary hypertension. People exposed to repeated stress may develop hypertension more frequently than others. Um, okay, let's go to next charts. While performing blood pressure screening at the health fair, the nurse counsels which person is having the greatest risk for developing hypertension. The answer is A. History of a close blood relative, example, father to son with hypertension is associated with an increased risk for developing hypertension. Atherosclerosis is the most common cause of cerebrovascular disease, and hypertension is the major risk factor for cerebroatherosclerosis and stroke. What clinical manifestations of hypertension would you assess in this patient? We will see hypertension is often called the silent killer because it is frequently asymptomatic until it becomes very severe and target organ disease starts happening. Symptoms of severe hypertension are fatigue, dizziness, palpitations, angina, and dyspnea. Um, so we'll stop this here, and this is 21 minutes slide, and we will continue this hypertension in the second part. So this is the continuation of our hypertension presentation. Uh, Now, hypertension is a silent killer, and you must have heard it many times. Now, why it's called a silent killer? Because it is frequently asymptomatic until it becomes so severe that it has led to any target organ disease. A patient with severe hypertension can experience symptoms which are secondary to its effects on blood vessels in the various organs and tissues, or they can be symptoms due to the increased workload of the heart. So patient with severe hypertension can experience a variety of symptoms, many symptoms which are secondary to the effects on blood vessels in the various organs and tissues in the body, or they can be symptoms secondary to the increased workload of the heart. Now, these secondary symptoms include fatigue, dizziness, palpitations, angina, and dyspnea. Now, in the past, symptoms of hypertension were thought to include headache and nosebleeds too. Unless BP is very high, these symptoms are no more frequent in people with hypertension than in any general populations. But patients who are undergoing any hypertensive crisis, they may experience severe headaches, dyspnea, anxiety, and nosebleeds. So the headache and nosebleed will only happen if the the hypertension is very high or it's very severe. So nosebleeds and headache is very severe, then that will happen. Otherwise, fatigue, dizziness, palpitations, angina, and dyspnea are commonly found with people with uh, severe hypertension. Okay, let's go to the next slide. Now, regarding the patients, patient which we were studying in this presentation, what complication this patient can have due to his blood pressure. Now let's learn about the complications. Now the target target organ diseases occur most frequently in the heart, brain, in the periphery of the body, in the peripheral vascular system, kidneys, and eyes. The most common complications of hypertension are target organ diseases. And target when I keep on saying target organ diseases, why? Because the blood vessels, arteries, arterioles, and the capillaries, they are supplying some target organs. And when there is a problem of blood pressure in your blood vessel, that in the arteries itself or in the arterioles itself, then they will damage the organ which they were supplying blood with. So if there is a hypertension, the most common complications of hypertension will be occurring in the target organ, which they are supplying the blood with, and these the most uh, important target organs of our body are heart, brain, kidneys, etc. And they will and you will see complications happening in these organs. In the heart, you can have something called hypertensive heart disease. In brain, you can have stroke, cerebrovascular disease. Cerebrovascular disease or stroke is same thing. And then peripheral vessels will get damaged and you can have peripheral vascular disease. In kidneys, slowly the filtering capacity or the tissue perfusion will decrease. And eyes, there can be a retinal damage. Retina of the eyes can be damaged. So this is a small cross section which is highlighted here, and the top picture of the heart, it demonstrates, it's showing that there was a lot of systemic vascular resistance by the blood vessels, and because of the systemic vascular resistance was high, the left ventricle muscle had to pump against a lot of resistance, and when it pumped against a lot of resistance, it led to a compensatory hypertrophy. And the bottom one is the normal one, the top portion is the abnormal one. So when there is an increased cardiac workload, the heart muscle starts adapting to it and it starts compensating, and then this compensatory mode will lead to hypertrophy of the left ventricle muscle because it's pumping against a high systemic vascular resistance. Okay, so the B is normal, A is abnormal. Okay, so the patient which we have been studying in this presentation was referred to his healthcare provider, doctor, to follow up on his high blood pressure screening. What diagnostic studies might you expect the healthcare provider to order for CS? So think about all the blood pressure um, diagnostic studies which the doctor can order for these patients. So some of the diagnostic studies which doctor can order for this patient is urine analysis, burn and serum creatinine, creatinine clearance, electrolytes, glucose, lipids, uric acid levels, ECG, and echocardiogram. Uh, Now there is some controversy as to what the diagnostic workup should be in the starting phase or in the starting assessment of a person who is having who who is having hypertension. Now, because most hypertension is classified as primary hypertension, and the testing for secondary causes is not routinely done. So there is some controversy as to what the diagnostic workup should be in the initial assessment of a person with hypertension. Well, anyhow, but some of the things which doctors might do routinely, normally, are lab studies. So the basic lab studies are performed to identify or rule out the causes of secondary hypertension, to evaluate any target organ disease, or to determine if there has been any cardiovascular risk, or to establish any baseline blood pressure levels before starting any therapy for the blood pressure. So the basic lab studies, why they are performed to first to identify or rule out causes of secondary hypertension, and then evaluate if there has been any target organ disease, and third, to determine if there is overall cardiovascular risk, and fourth, to establish baseline levels before starting any therapy. Now, routine urine analysis, BUN, and serum creatinine levels are used to screen for renal involvement and to provide baseline information about the kidney function. Um, as I said earlier, what happened first? The kidney got damaged first, and that led to the high blood pressure, or high blood pressure happened first, and then it led to the kidney damage. And this is one of the things which is also in which is also in controversy. But anytime there is a patient with hypertension, his kidney function will be assessed too, and there will be a routine urine analysis, BUN, and serum creatinine levels, which will be screened to get to get the knowledge as how much there is renal involvement in this hypertension. Now, what is creatinine clearance? Now, creatinine clearance will reflect the glomerular filtration rate. And the glomerular filtration rate, it um, will if it it'll now glomerular filtration rate will show the creatinine clearance, and if there is a low um, level of creatinine clearance, then it will indicate that there has been some kind of a renal insufficiency, and because of that the blood pressure might be happening. Now, measurement of electrolytes, especially potassium, is important to detect one of the causes of hypertension, which is hyperaldosteronism, and which is a cause of secondary hypertension. So, if we are doing some electrolytes measurement, we are looking especially towards potassium because it can help in detecting hyperaldosteronism, which is one of the causes of hypertension. Now, the blood glucose levels will assist in the diagnosis of diabetes mellitus. A lipid profile will provide information about any other risk factors that led to atherosclerosis and cardiovascular disease. Uric acid levels, it establishes a baseline because the levels often rise with diuretic therapy. So analyzing uric acid levels will establish a um, baseline assessment of what's happening with the body, with the body's blood pressure, because the uric acid levels often rise if the patient was any diuretic therapy. And ECG provides baseline information about cardiac status. It can identify the presence of any cardiac ischemia or previous MI. If there is some kind of cardiac ischemia or it is suspected, then echocardiography can be also performed. Now, if the patient's age, history, physical examination, or severity of hypertension points to any other secondary cause, further diagnostic testing is indicated. And all throughout, when I'm saying secondary to this, it means in simple ways, as like if you have seen patients on floor with a diagnosis hypertension, then you look at their comorbidities, you look at their other diseases which they might be having, and then you might assess, oh, he's having blood pressure because he has a kidney disease. Oh, he's having high blood pressure because he has some cardiovascular problem going on. So, hypertension can be secondary to many other diseases, and mostly it's cardiovascular diseases. So let's go to the next slide. Now there is something called ambulatory blood pressure monitoring. What is ambulatory blood pressure monitoring? The ambulatory blood pressure monitoring is a non-invasive, fully automated system that measures BP, blood pressure at preset intervals over a 24-hour period. You can just it's just like it's not exactly like Holter monitor, but it's something like Holter monitor because it will be screening patients' BP over a period of 24 hours. And there'll be like preset intervals on which it is screening the patient for its BP. Now, the equipment of this the automatic blood pressure monitor will include a BP cuff. There'll be a cuff, blood pressure cuff, and there is a microprocessing unit that will fit into a pouch, which is worn on a shoulder strap or belt. And we teach patients to hold their arms still and keep a diary. And we we tell them why to hold their arm because when the device is taking a reading, if they move their uh, if they move their arm, it can give a false reading. And we also ask them to maintain a diary of activities that may have affected BP. So there is a device and it takes blood pressure at preset intervals, and when the that monitor or that machine is taking the blood pressure, we tell the patient that at that time you hold your arm still so the blood pressure reading uh, can be accurate. It is useful for patients who have high BP readings uh, in a clinical setting and normal readings when BP is measured elsewhere. This phenomena is now there is something called white coat hypertension. So white coat hypertension is like um, they have the patient has elevated BP readings in a clinical setting and they have normal readings when BP is measured elsewhere. So other potential applications for this ambulatory blood pressure monitor to study hypertension includes if there is any drug resistance, any body is presenting any antihypertensive drug resistance, or body is presenting any low BP symptoms with any blood pressure drugs, or there is some kind of episodic hypertension. So that's why the ambulatory blood pressure monitoring will give more information. Now, blood pressure at night, or during sleep, it usually drops by 10% or more from daytime. So some patients with hypertension will not show do not show a normal nocturnal dip in BP, and they are referred to as non-dippers. So usually, if you sleep in the night If you don't, like if you have not have hypertension, then our blood pressure usually drops by 10% in the night. But some patients will not show this, a normal night blood pressure dip, and so they are referred to as non-dippers. Nondippers. Now, if there is an absence of nocturnal blood pressure drop, then it has been associated more with any target organ disease and an increased risk for cardiovascular diseases. And if the presence or absence of um, the blood pressure dropping in the night or not can be determined by this ambulatory blood pressure monitoring system. So um, let's go to the next slide. Case study. We are continuing with the case study. The blood pressure, the the patient's blood pressure was monitored for several visits and it remains elevated. His cholesterol, burn, and creatinine levels were also elevated. His creatinine clearance, which reflects the glomerular filtration rate, was below normal, demonstrating renal insufficiency. Um, Now, what type of lifestyle modifications would you recommend for CS to control his blood pressure? I think the one which is immediate is weight reduction, then exercise, some dietary changes, stress reduction, and smoking cessation. Overall collaborative care, the overall goals for hypertension will be to control blood pressure, definitely, and also to reduce any CVD risk factors and target organ disease. Uh, Lifestyle modifications directed towards reducing the patient's blood pressure is very important. And it's not only important for the patients who have hypertension, but also for patients who have pre-hypertension readings. So they also should make some changes in their life so their blood pressure is accurately controlled. Weight reduction and DASH eating plan. I think most of you must have heard about the DASH eating plan. So let's talk about DASH eating plan. The DASH eating plan is just emphasizes um, fruits, vegetables, fat-free or low-fat milk and milk products, whole grains, fish, poultry, beans, seeds, and nuts. Compared with the typical American diet, the plan contains less red meat, salt, sweets, added sugars, and any sugar-containing beverages. The DASH eating plan significantly lowers the patient's BP, and um, the these decreases they are compared with those achieved with blood pressure drugs. So if the patient is adapting a DASH eating plan, it will show significant drop in BP, like significant decrease in BP, uh, and it will benefit patient just as much as if he was on any hypertensive drug therapy. Additional benefits also include uh, lowering of LDL cholesterol. So DASH does not even help with DASH not only helps with lowering the BP for the hypertensive patient, but it also helps in reducing the LDL cholesterol. Weight reduction. Overweight persons have increased incidence of hypertension and increased risk for cardiovascular diseases. Weight reduction has a significant effect on lowering BP in many people, and the effect is seen with even moderate weight loss. A weight loss of 22 pounds may decrease, which is just like 10 kg, may decrease blood pressure, may decrease systolic blood pressure by approximately 5 to 20 millimeters of mercury. So 10 kg decrease of weight loss can lead to decrease of 5 to 20 millimeters of mercury blood pressure. Um, when the person decreases caloric intake, sodium and fat intake are usually also reduced. Although reducing the fat content in the diet has not been shown to produce sustained benefits in blood pressure control, but it may slow the progress of atherosclerosis and thereby reduce the risk of cardiovascular disease, which is one of the greatest cause of hypertension. And weight reduction through a combination of calorie restriction and moderate physical activity is recommended for overweight patients with hypertension. So these are the lifestyle modifications, and think about the kind of questions NCLEX and I can ask regarding the lifestyle modifications. Physical activity, it's moderate intensity aerobic activity at least 30 minutes most days of the week. Vigorous intensity aerobic activity at least 20 minutes 3 days a week. And then muscle strengthening activities at least 2 times a week. Flexibility and balance exercises two times a week. Um, Now, a physically active lifestyle is very important to promote and maintain good health. The American College of Sports Medicine, they recommend that adults perform moderately intense aerobic physical activity for at least 30 minutes most days. That is more than 5 per week, or vigorous intensity aerobic activity for at least 20 minutes 3 days a week. Now, the 30-minute goal can be accomplished by performing shorter periods of exercise that last at least 10 minutes or more. Now, the overall, the if the physical activity is enjoyable and it's safe, then it has more benefits and it fits easily to one's daily schedule and is inexpensive. So the goal should be to not uh, uh, not go for those high tech things. So if the patient is diagnosed with hypertension, so here goes show they go and they buy the treadmill, $700-800 treadmill, and they buy $1,000 elliptical, and now they think they have done the exercise. No, it can be done in inexpensive, enjoyable, and safe manner. And it has been recommended that for adults age 18 to 65, walking briskly at a pace that noticeably increases the pulse defines the moderate intensity aerobic activity. Jogging at a pace that substantially increases the pulse and causes rapid breathing is an example of vigorous activity. So, jogging is one of the means. And when you're walking, the walking should be done briskly, because when the pulse increases moderately, that means it's trying to build up your metabolism. And this is good for your heart. Avoidance of tobacco products. Nicotine causes vasoconstriction and high BP, and smoking cessation reduces risk factors within 1 year. So I cannot talk enough about tobacco. Now, my tobacco, because we have dealt with smoking earlier, uh, smoking is also a major risk factor for cardiovascular disease. Uh, and if the patient stops tobacco use, they can see the results within 1 year. Um, Now, if the patient has been using tobacco and you encounter this patient, tell them to monitor their BP when they are taking those tobaccos. Okay. Um, Now, there is also a psychosocial risk factors. Sometimes there are low socioeconomic status, social isolation, there is no support, stress, and that can also lead to hypertension, um, because sometimes the psychosocial risk factors can have direct effects on the cardiovascular system by activating the sympathetic nervous system and stress hormones. This can cause a wide variety of uh, pathophysiological responses, including hypertension. So there are some psychosocial risk factors also for hypertension, and we can think about how we can modify these so the blood pressure can be better managed. Now, in addition to lifestyle modifications, the patient which we are studying in this presentation, the healthcare provider, it prescribes him hydrochlorothiazide. Now, hydrochlorothiazide is a diuretic. Now, what would you teach CS about this drug? Now, this drug is a diuretic that will increase the amount of water which is excreted in the body from the urine. Now, decreasing the amount of fluid circulating in your bloodstream will work to decrease your blood pressure. So, low volume, low pressure. So, diuretics, by taking out the fluid circulating in your bloodstream, they're trying to lower the blood pressure. Now, the patient teaching can be that they should take this in the morning to prevent any nocturnal diuresis. So, otherwise, at the day during the evening, before they're going to bed, then they'll be going to bed all night. So, taking in the morning is better, and they should change position slowly to prevent a sudden drop in blood pressure or orthostatic hypotension. So, a sudden drop in blood pressure can happen while taking hydrochlorothiazide. So, they should change position slowly. Now, they should use sugarless gum or hard candy to help ease dry mouth that may occur. So with hydrochlorothiazide, dry mouth can occur. So they should have some sugarless gum or hard candy to help ease the dry mouth that may occur if the patient is using hydrochlorothiazide. Okay, so I just took a moment's break because I wanted to drink water. Um, so just remember the teaching regarding hydrochlorothiazide. Um, Now, once anti-hypertension therapy is started, patients should return for follow-up and adjustment of drugs at monthly intervals until the goal of the BP is reached. More frequent visits are necessary for patients with stage 2 hypertension or patients who have hypertension as well as the other diseases. After BP is at goal and it's stable, then the follow-up visits can usually be 3 to 6 months intervals. Now, side effects of um, antihypertensive drugs are common and may be so severe or undesirable that the patient does not comply with therapy. Patient and caregiver teaching related to their drug therapy may help the patient comply with therapy. So it's very important to give them some information about the drug, their pros and cons, and how the pros is important for the for bringing the blood pressure to normal levels, and also teach them the side effects may be an initial response to a drug and it might decrease over time. Um, and if you tell the patient that this is the side effect and it might go over time, then it might encourage the patient to continue taking the drug. Uh, the side effects, as you all know, can also be related to the uh, how much drug the patient is receiving. So maybe sometimes decreasing the doses can also help. And the common side effect of several of the blood pressure drugs is orthostatic hypotension. And this condition results from an alteration of the body's autonomic nervous system mechanism for regulating the BP, which are required for position changes. So consequently, the patient may feel dizzy and faint when assuming an upright position after sitting or lying down. So, a common side effect of several of these drugs is orthostatic hypotension. Um, Sexual dysfunction can occur with many of the antihypertensive drugs and can be a major reason that patient doesn't want to comply with the blood pressure medicine. Now, problems can range from reduced libido to erectile dysfunction. Rather than discussing a sexual problem with the healthcare provider, the patient may decide just to stop taking the drug. And yes, and you also keep this in mind that the sexual problems, whether they need to be discussed with the doctor, also depends on the patient's background from where they are. Like most of the people who have been um, in the more liberal kind of American culture, they don't have problem in discussing their situation with the doctor. But many people, as I know, I'm from India and many other Asian countries or some European countries, the patients, whether it's man or woman, they don't want to discuss that, they started this drug, now their libido is decreased. So if you feel that some kind of uh, if you feel some kind of hint by a patient regarding this problem, then you should investigate more and deal it with in a best cultural sensitive manner. So, and diuretics, they cause dry mouth and they frequent voiding. So sugarless gum or hard candy may help ease dry mouth. And the side effects of vasodilators and adrenergic inhibitors decrease if the drugs are taken in the evening. So because BP is lowest during the night and highest shortly after awakening, drugs with a 24-hour duration of action should be taken as early in the morning as possible, maybe like 4 or 5 a.m. if the patient gets up to go to the bathroom. Advise the patient to report all side effects to their doctors if they have on any blood pressure drug. The thing which I have found in most of the patients is itching. Some blood pressure drugs leads to itching. Nursing assessment, you will look at the past health history. So you will gather the subjective data. You will look at the past health history, hypertension or any heart disease, any diabetes, any obesity, menopause, or hormone replacement, and the duration and past workup of high BP. Um, I mean, drugs, if the patient is using any drugs, over the counter drugs, any herbal drugs, or if they had used antihypertensive drugs before. Then you can look at the other data, and this will be regarding the functional health patterns. So you can talk about the family health, family history, salt and fat intake, weight gain, or loss, nocturia, fatigue, dyspnea or exertion, palpitations, dizziness, blurred vision, erectile dysfunction, stressful events. Now, coping stress tolerance is very important because that can lead to blood pressure, high blood pressure too. Erectile dysfunction is equal to decreased libido. So you need to assess that. Then dizziness, blurred vision, etc., is due to the lack of cognitive perceptual, due to the loss of cognitive perceptual function of the body. Activity, exercise, how activity or exercise is getting affected by the blood pressure, and then how much salt and fat is being included in patient's diet. And family history is important. Uh, if there have been people in family with hypertension or cardiovascular disease, or somebody in the family uses tobacco use has been prevalent, or alcohol use has been prevalent, or overall the sedentary lifestyle has been prevalent in the family. So it's important to ask questions about these. objective data. Objective data is always something which you can verify. So we need to perform a focused physical assessment, and the cardiovascular regarding cardiovascular assessment will look at the systolic blood pressure to see if it's going above 140, or diastolic if it's going above 90. We can see if there is any orthostatic changes in BP and pulse, and or we'll see if that the bilateral BPs are significantly lower, or if there is any abnormal heart sounds, or we can look at any absent or weak peripheral pulses, or we can look for any presence of peripheral edema. Body measurements is equal to BMI. So think about BMI. If the BMI is greater than or equal to 30 kg per m squared. Now, abnormal waist hip ratio will also affect it. Neurologic, look at any mental status changes if it's happening and leading to. Is there been mental status changes in the patient while gathering data on hypertension? Um, Take measurement in both arms, proper size and placement of cuff. And I don't need to repeat a lot on this because you have done this in your fundamentals. And by fourth semester, you should be knowing what goes wrong if uh, the cuff size is not good, and how to take the highest BP. So initially you should be taking the BP in both arms to note any differences. Uh, if the patient has atherosclerosis, then atherosclerosis in the subclavian artery can cause a falsely low readings on the side where the narrowing of the arteries are occurring. And they use the arm with the highest BP and take at least two readings, at least 1 minute apart. Waiting for at least 1 minute between reading will allow the blood to drain from the arm and prevent the inaccurate readings. Proper size and correct placement of BP cuff is important, and BP cuffs that are too small, too large will result in readings that are falsely high or low. And you can see how the patient's arm is at what level when the nurse starts taking the patient's blood pressure. Now, if neither upper arm can be used to measure BP, example, there is presence of IV lines or fistulas, or if a maximum size BP cuff does not fit the upper arm, then you can use the forearm. In this case, you position the proper size cuff midway between the elbow and the wrist, and then auscultate that cough sounds over the radial artery, or use a Doppler device to note the systolic BP. Now, the use of this oscillometric device on the forearm is acceptable. Forearm and upper arm BPs are not interchangeable. If using the forearm for BP measurement, always document the side that you took the BP from forearm, and assess for any orthostatic hypertension, BP, and uh, assess for any orthostatic hypertension. And in people taking hypertensive drugs, and the patient who reports symptoms which are kind of consistent with low BP, so take note of that. Measure the serial BP and pulse with the patient in the supine, sitting, and standing positions. Uh, Usually, the systolic blood pressure decreases slightly, less than 10 millimeter mercury on standing, whereas the diastolic blood pressure and pulse increases slightly. A decrease of 20 millimeter mercury or more in systolic blood pressure, a decrease of 10 millimeter mercury or more in diastolic blood pressure, and or increase in the heart rate of greater than or equal to 20 beats per minute from supine to standing indicates orthostatic hypertension. So I'm repeating it. A decrease of 20 millimeter mercury or a decrease, low, a decrease of 20 millimeter mercury or more in systolic blood pressure, a decrease of 10 millimeters mercury or more in diastolic blood pressure, and or increase in the heart rate of greater than or equal to 20 beats per minute from supine to standing, that indicates orthostatic hypertension. And common causes of orthostatic hypertension will be the intravascular volume loss and inadequate vasoconstrictor mechanisms related to disease or drugs. So let's go to the next. These are some of the nursing diagnoses related to hypertension: ineffective self-health management, anxiety, sexual dysfunction, risk for decreased cardiac perfusion, risk for ineffective cerebral and renal perfusion, and potential complications, stroke, and MI. Now, I have been reading some SIM charts, and we were discussing some care plan, the nursing diagnosis. Now, if you see in the list of these nursing diagnoses, the risk for these two diagnoses, the risk for diagnosis is something, um, if you are on the floor, you would be careful of, but they are not your priority nursing diagnosis. Your priority nursing diagnosis, if I have to pick from these lists of diagnoses here, I would pick the potential complications, the stroke, MI. I would pick anxiety. I would pick ineffective self-health management and sexual dysfunction. So I will keep in mind the patient's risk for the other things because of the hypertension, but my focus will be always to calm down the anxiety if I'm on the floor with this patient, to manage this patient's BP better and to educate him as much as possible on the knowledge of his disease complications and how he can manage it. So when you have nursing diagnosis, think on these terms first. Nursing planning, yes, the BP should be maintained, and the patient should understand what's happening with his therapy, and minimum side effects of blood pressure therapy, drug therapy, and they should be confident that they can manage and cope with this condition. Primary prevention via lifestyle modification, individual patient evaluation and education, screening programs, uh, and you all have been participating in the blood pressure screening clinics this semester too. They are widely used to check, the screening programs in the community are widely used to check individuals for high BP. At the time of the BP measurement, give each person a written numeric value of the reading. If necessary, explain why further evaluation is needed. And the effort and resources should focus on the following: controlling BP in persons already identified as having hypertension, identifying and controlling BP in at-risk groups such as African Americans, obese people, and people who have blood pressure diagnosis running in their family. So, and also when you're doing your screening programs, you also teach regarding the cardiovascular risk factors and how they can modify it. So some of the cardiovascular risk factors which you just learned in your last topic was hypertension, was obesity, diabetes, tobacco use, and also sedentary lifestyle. Ambulatory and home care, your primary responsibilities for long-term management of hypertension is to assist the patient in reducing his BP and complying with the treatment plan. Your nursing action should include, if I am telling the patient to do so and so, and if we are supporting him, then how we should evaluate the therapeutic effectiveness of your plan, how it's progressing. because the common problem in evaluating the therapeutic effectiveness um, of the antihypertensive therapy is that the patients don't comply with this. There is a poor compliance attached with the treatment plan for hypertension, and there can be many reasons. The common one can be that there's an inadequate patient teaching, or there has been they experience unpleasant side effects of drugs, or the lack of motivation, and the common one these days is also high cost of drugs, lack of insurance, and a lack of trusting relationship between the patient and the doctor. And talking about the insurance, um, I don't know, I had a patient who said, I am not taking this blood pressure drug. It was Mecardis or something. I was not taking this blood pressure drug because for a month supply I have to give $500. And I was like, what? Yes, they for the month supply because something happened with the drug, and the drug was not, the brand name was not being made, and the generic was being offered, and that was not covered with his insurance, or he had some problem with insurance, and he has to pay $500 just for that blood pressure drug. So before you, if the patient is not taking blood pressure medicines or is not compliant, before judging him that he's non compliant, you will try to rule out all the other causes attached, um, and then you will individually assess each patient, determine the reasons why the patient was not compliant with the treatment. The plan should be always customized to the patient's habits and lifestyle. Then only he'll be interested to follow it. Now, patient and caregiver teaching, whether it's diabetes, whether it's hypertension or chronic disease, all these diseases has one thing in common. They are all chronic diseases, chronic illnesses which cannot be cured, but they can be managed. So emphasize that it can be, in the blood pressure, hypertension can be controlled with drug therapy, diet changes, physical activity, and follow-up, and other lifestyle modifications. So this is not the end of the world. So it is a chronic disease, but it can be managed, and they can live happily for many years if they follow what their healthcare provider and the other nursing and related staff is teaching them. These are some of the reasons for non-compliance. Inadequate teaching. So now, inadequate teaching, I have a very interesting episode to tell you. I had a patient, one of the schools where I taught, I had a group of students on the floor and on the Kaiser floor. And Kaiser has a very good system of, um, KP learning. It's like, where you can, there's a website, where you can get a lot of information on the diseases, patient teaching and everything, and patients can go there too, and they can look about get the information about any disease, how to cope with it, how to get a follow-up appointment, and how to manage it. Now this girl said, I did my teaching for this patient. I said, okay, so what did you teach? And she wrote on the paper which they were supposed to submit at the end of the clinical, I referred patient to KP learning website, so HTTP so and so. Now this was not correct. This was because before, and this is a 74-year-old patient who has no access to computer, and she's telling him to go to this website to get the teaching. I would expect from all my students, whenever they become RNs and they are doing teaching, you assess accurately how much teaching your patient is understanding, and there are different ways where they can show you whether they are understanding. So you give them handouts, see whether they can read first or not. If they cannot read, then you have to, then you at least speak the terms, major terms from your teachings, major topics from the teaching, and see whether they're wearing glasses or they have any problem with hearing aid, and then you could start teaching and give them as much handouts or big print material so it's convenient for them to read. um, I would never tell my patient to go to this website to get the teaching. I will give at least the most important teaching to the patient myself and will assess the understanding by his demonstration or his verbally telling me everything. So that's important. And during the last week in our clinicals, Jackie, she did a very good teaching on diabetes to a patient, and I was impressed. This was a newly diagnosed patient with diabetes, and she brought the syringe, the insulin, the drug, and the book, the and also the blood sugar check machine, and she demonstrated, and she asked the patient to do it for him, and he did it for her. And this was a very good teaching which I observed with Jackie in ICU last week. So teaching is not just saying 4 lines and getting patient signature and going. um, Side effects of the drug is one of the other reasons why the patient can be non-compliant. Then the nurse needs to dig a little more and talk to the doctor if possible, and see if they can reduce the dose or something. Um, and the reasons for non-compliance is that if the blood pressure returns to normal, they don't take any blood pressure medication. Well, this is a chronic disease. They need to take their blood pressure accurately, after taking their BP measurements regularly. There can be a lack of motivation, financial reason, or lack of trust, as I discussed earlier. So what can we do to increase this patient's compliance with his medication and lifestyle changes? So measures to enhance compliance can be customize the plan to patient's needs. Patient's active participation should be encouraged, and affordable drugs should be selected. We can involve the doctors. Combination drugs, substituting combination drugs for multiple drugs once the BP is stable may also facilitate compliance. So suppose if the patient was on 4 blood pressure pills and he was on 3 blood pressure pills, and then the doctor can say just by giving uh, uh, 2 drugs, a combination drugs, maybe that will be helpful, so we can reduce the number of blood pressure pills. So that can also encourage compliance. So, and also do a lot of patient teaching, how a patient just by being proactive can manage his BP better. So this is a kind of repetition of what I have said earlier. And patient, the CS returns to his healthcare provider office for a follow-up visit 3 months after starting on hydrochlorothiazide. Now, how would you evaluate the effectiveness of his treatment strategies? So, while evaluating, patient will see that did he achieve any his target goal BP, and the patient, did he understand and accepted and implemented the therapeutic treatment plan of BP, and is he experiencing minimal or no unpleasant side effects of therapy. So all these factors will help in evaluation of the treatment plan. Now, this is a question: a patient's blood pressure has not been responded consistently to prescribed drugs for hypertension. The first cause of this lack of responsiveness the nurse should explore is the patient not adhering to therapy. See, so non-compliance is one of the biggest problems. So the patient blood pressure is not responding to drugs, and the first cause the nurse should explore is the patient not adhering to therapy, because the side effects of the antihypertensive drugs are very common, and so they can be so severe for the newly diagnosed hypertensive patient or undesirable for some patients that the patient does not want to take medicine. Geriatric consideration of this disease is that it is higher in people with old age, and the isolated systolic hypertension is the most common form of hypertension in people over 50 years of age. Um, Most common form, older adults are more likely to have white coat hypertension, and an age-related physical changes also contribute to hypertension. And some of the age-related hypertension which can contribute to the hypertension is loss of elasticity in large arteries from atherosclerosis, increased collagen and stiffness of the heart muscle, increased peripheral vascular resistance, low adrenergic receptor sensitivity, blunting of the baroreceptor reflexes, and also decreased renal function or decreased uh, hormone renin response to water and sodium uh, depletion. So there can be various changes in the old age which can automatically lead to hypertension. So older adults are more likely to have white coat hypertension. So I explained so much. How about you discover about, I did explain white coat in a small way in the earlier slide, in a little way, but I want you to tell me in the class, if you heard it before the class, that what is if you hear this video before the class, that what is white coat hypertension. um, Hypertension in older, there is can be older. Now in old age, some of the drugs absorption in the body can also change, so that can also affect the person who's taking the antihypertensive drug. And in old age, there is often a wide gap between the first cough sound and the subsequent beats, and there can be a lot of auscultatory gap. So in some older people, there can be a wide gap between the first cough sound and the subsequent beats, and this is called the auscultatory gap. Failure to inflate the cuff high enough may result in underestimating the systolic blood pressure. High risk for hypertension is common in older persons, and also postprandial hypertension. Older adults experience postprandial drops in blood pressure. The greatest decrease occurs approximately after 1 hour after eating. Approximately 1 hour after eating. BP returns to preprandial levels 3 to 4 hours after eating. Avoid giving vasoactive drugs with meals. So vasoactive drugs with meals should not be given because they have their blood pressure, older person's blood pressure gets affected by eating too. There is something called hypertensive crisis, and hypertensive crisis is a term used to indicate either a hypertensive urgency or emergency. This is determined by the degree of target organ disease and how quickly the blood pressure must be lowered. A hypertensive emergency develops over hours to days. It is a situation in which a patient's BP is severely elevated, very much elevated, and it's often greater than 220 over 140, with clinical evidence of target organ disease. Now, what is hypertensive urgency? Hypertensive urgency develops over days to weeks. So, hypertensive emergency, it develops over hours to days. Hypertensive urgency develops over days to weeks. And this is a situation in which a patient's BP is so much elevated, is severely elevated, usually above 180 over 110. but there is no clinical evidence of target organ disease. So know the difference between the hypertensive and hypertensive, emergency and urgency. And the rate of the rise of BP is more important than the um, absolute value in determining the need for emergency treatment. Patients with chronic hypertension can tolerate much higher BPs than a patient who doesn't have these high BPs. Prompt recognition and management of hypertensive crisis is very important, so the organ dysfunction or organ damage doesn't happen. So when this happens, when the patient is going with hypertensive emergency or a crisis, now hypertensive crisis can be in two ways: hypertensive emergency and hypertensive urgency. Now hypertensive emergency, you can see the blood pressure is very high, and in hypertensive urgency the blood pressure is high but it's still below 200, the systolic one I'm talking about. So when you have this, you need to act fast. And what do you think, based on these, um, in what BP, in what situation, in the emergency or urgency, the IV blood pressure medicine must be given? So think about that. Okay. Or there can be some other, like IV, some other IV therapy done to reduce the BP. Hypertensive crisis, clinical manifestation: hypertensive encephalopathy, renal efficiency and cardiac decompensation, and aortic dissection. A hypertensive emergency is often shown as hypertensive um, encephalopathy, a syndrome in which a sudden rise in BP is associated with severe headache, nausea, vomiting, seizures, confusion, and coma. The manifestations of encephalopathy are the result of high cerebral capillary permeability. This leads to cerebral edema and a disruption in the cerebral function of the body. On retinal examination, you can see some exudates, hemorrhages, or even papillary edema. So hypertensive emergency is often manifested as hypertensive encephalopathy, and you can see a patient experiencing headache, nausea, vomiting, seizures, confusion, and coma. Renal insufficiency ranging from minor injury to complete renal failure can occur. Rapid cardiac catheterization, rapid cardiac decompensation ranging from unstable angina to MI, and pulmonary edema is also possible. Aortic dissection can develop and will cause sudden excruciating chest and back pain and possibly reduced or absent pulses in the extremities. So when there is hypertensive emergency, it requires hospitalization. And as I was saying, there will be an IV therapy done. So IV administration of antihypertensive drugs will be done, and intensive care monitoring. When treating hypertensive emergencies, the mean arterial pressure is often used instead of BP readings to guide and evaluate drug therapy. We'll monitor the cardiac renal function, we'll do some neurological checks, we'll determine the cause, why there was so much of high BP, and we'll educate the patient after patient has become moderately stable to avoid future crises. The patient will need appropriate management and teaching to avoid future crises. Now, antihypertensive drugs, when they were administered via IV, have a rapid onset of action, so within seconds to minutes. So you need to assess the patient's blood pressure and pulse every 2 to 3 minutes during the starting phase of the administration of these IV hypertensive drugs. You have to titrate the drug or adjust the drug according to the patient's mean arterial uh, map, mean arterial pressure or blood pressure as ordered. Monitor the ECG for any cardiac dysrhythmias or sign of MI. You have to measure the urine output hourly to assess renal perfusion. And patients receiving IV and antihypertensive drugs may be restricted to bed for a while. And getting up, example, to use the commode, etc., may cause several severe cerebral ischemia and fainting. So they need to be in the bed. And they need a lot of monitoring if they get admitted to the hospital with hypertensive emergency. The nurse takes note nurse takes blood pressure at a health fair. The nurse identifies which person is at most risk for developing hypertension. A 52-year-old male who smokes and has a parent with hypertension, a 30-year-old female who is unmarried, lives alone, a 68-year-old male who uses herbal remedies to treat and prostate gland, and a 43-year-old female who travels extensively for work and exercises only on weekends. And I don't think I need to tell the answer because it's quite clear. It's number one, the person who smokes. Hypertension is more prevalent in men who are less than 55 years of age. Smoking tobacco greatly increases the risk of cardiovascular disease. A history of a close blood relative, example, parents or sibling with hypertension, is associated with an increased risk for developing hypertension. Also, the other risk factors can include increasing age, sedentary lifestyle, and stress. The nurse determines which of the following blood pressure would meet the criteria for a diagnosis of stage 2 hypertension. Stage 2 hypertension is diagnosed when the systolic blood pressure is greater than or equal to 160 millimeter mercury, or the diastolic blood pressure is greater than and equal to 100 millimeter mercury. So the answer is 4. Number 4, 182/94 is the correct answer. A patient's blood pressure has not responded to the prescribed drugs for hypertension. Which of the following should the nurse assess first? I think I repeated the same question. Patient's adherence to drug therapy. So this brings to the end of our hypertension presentation. So regarding chapter 38, you have earlier e-lecture of peripheral arterial disease, and this is the second one, hypertension. And in the earlier lecture of peripheral arterial disease, in the first slide, in the second slide, I have directed what readings you have to do from chapter 38. Okay, so my next following lecture will be on shock. Okay, thank you.